All right, today we're going to break down the first ever AASLD practice guidance on reproductive health and liver disease. This is a topic that you're absolutely going to see whether you're heading into hepatology, OBGYN, or even primary care. So we're going to distill this whole thing into a practical guide you can actually use at the bedside.
So let's kick things off with a pretty basic question. Why on earth should a liver specialist be asking about birth control? Well, it's easy to think this is all about pregnancy, but it's so much broader than that. A lot of patients with chronic liver disease struggle with fertility, and that can create this false sense of security. But here's the thing, pregnancy is absolutely possible even in someone with decompensated cirrhosis, and that's why getting ahead of it with proactive counseling is so important.
Okay, a quick but really important point here. What we're talking about is a practice guidance, not a practice guideline. And you might be thinking, what's the difference? Well, a guideline is the gold standard, right? It's backed by tons of big, randomized controlled trials. This guidance, on the other hand, is built on the consensus of experts, basically because we just don't have that high-level trial data yet. It means this is the best approach we've got, but it also means your clinical judgment is still a huge piece of the puzzle.
So here's our game plan. We're going to start with the basics, the hormonal chaos. Then we'll talk about being a proactive clinician with contraception. After that, we'll tackle the tricky liver diseases that only pop up during pregnancy, then dive into the high-stakes world of pregnancy with cirrhosis. And we'll wrap it all up with the big takeaway message.
First up, the foundation. So why is the liver so tangled up with reproductive health anyway? It all comes down to one thing: hormones. A sick liver completely throws the body's hormonal system out of whack.
Now, what's really wild is how this plays out so differently in men and women. For women, the liver can't process estrogen properly, and that messes with the whole brain-to-ovary signaling pathway. The result? Irregular periods, or sometimes no periods at all. For men, it's almost the opposite problem with estrogen. Their testosterone levels plummet, and their bodies start converting more of their androgens into estrogen. This leads to things like erectile dysfunction and testicular atrophy.
Okay, so that's the why. Now for the what do we do about it? Knowing all this, we've got to be proactive, and that journey starts with contraception counseling.
This table tells you pretty much everything you need to know. For your highest risk patients, we're talking decompensated cirrhosis, certain liver tumors, or a failing transplant. The big enemy is estrogen. Just look at that table. Combined hormonal methods with estrogen are completely 100% unacceptable, a huge no-go. But on the flip side, things like IUDs and progestin-only options are generally good to go. So the key isn't avoiding all hormones, it's about avoiding estrogen.
And just to really hammer this point home, here it is straight from the guidance. Seriously, you should memorize this list. If your patient has decompensated cirrhosis, Budd-Chiari, HCAs, or graft failure, estrogen is off the table. This is one of those critical, can't-miss takeaways that will keep your patients safe.
Okay, let's switch gears. What happens when your patient is pregnant? Well, now we're facing a whole new set of challenges. Liver diseases that literally only exist because of pregnancy.
Before we go any further, let's get one rule straight, and this is non-negotiable. Liver enzymes should not go up in a normal pregnancy, period. If you see any bump in their LFTs, their bilirubin, their bile acids, that is a red flag. It's always abnormal, and it always needs a workup. Don't ever let someone tell you it's just a normal change of pregnancy. It's not.
And this timeline, this is your best friend when you're trying to figure out what's going on. The timing tells you so much. If it's the first trimester, you should be thinking about hyperemesis gravidarum. As you move into the second and third trimesters, things like intrahepatic cholestasis of pregnancy or ICP are on your radar. And then late in the game, in that third trimester, that's when the really scary stuff can pop up, like preeclampsia, HELLP syndrome, and acute fatty liver of pregnancy. This timeline helps you narrow down the possibilities right away.
All right, now for the scenario that keeps hepatologists up at night, managing a pregnant patient who already has cirrhosis. This is where careful, proactive planning can mean the difference between a great outcome and an absolute disaster.
Being proactive is everything here. Let's take a patient with hepatitis B cirrhosis, for example. We have to prevent passing that virus to the baby. And the magic number you need to burn into your brain is 200,000. If that maternal HBV DNA level is over 200,000, you are starting tenofovir in the third trimester. It's critical. Now let's talk about the biggest risk to the mom.
So, what are we most worried about? What is the thing that we are absolutely terrified of? It's this: bleeding from esophageal varices. See, pregnancy itself creates this state of high blood flow.
which is a lot like what cirrhosis does. When you pile that on top of existing portal hypertension, the risk of a variceal bleed goes through the roof. And a bleed during pregnancy can be catastrophic.
So how do we prevent it? The guidance gives us a super clear 3-step playbook. Step 1, you have to screen them with an endoscopy before they get pregnant, ideally within a year of trying. Step 2, if you find varices, you treat them, no question. You start them on beta blockers or you do banding. Step 3, and this is a big one, if that preconception scope was clean and their liver disease is stable, you don't need to put them through another endoscopy during the pregnancy.
And that brings us to our final and honestly most important point. If you remember absolutely nothing else from this entire explainer, please remember this. You cannot do this alone. The guidance itself could not be more explicit about this. From the moment a patient even thinks about getting pregnant, all the way through postpartum care, a team approach is the only way to go. This isn't just a nice suggestion, it's the standard of care.
So who's on this dream team? Well, at the bare minimum, you need these 3 players. The hepatologist managing the liver, a maternal fetal medicine or high-risk OB specialist managing the pregnancy, and a pediatrician who's ready to take care of the baby. That's your central core team.
So I'm going to leave you with this question to take back to your own practice. This isn't just about knowing the science. It's about building the systems to deliver great care. How are you going to identify your FMM colleagues? Who's the pediatrician you can call? How will you set up these lines of communication before you have a complex patient sitting in front of you? Because building that team is the very first step to putting all of this guidance into action and ultimately saving lives.